Okay, and hello and welcome to the latest ARMA webinar, which is everything you wanted to know about setting up a musculoskeletal service, but were afraid to ask. My name's Sue Brown and I'm the Chief Executive of Pharma. ARMA webinars are free to access thanks to our partners, and we are really grateful to Roche Products Limited and Chugai Pharma UK for their support of this webinar. Before we start, I'm just going to try and find out who we have on the webinar today. So I'm just going to launch a poll, just asking who you are. And if you can just, those of you who are not on the phone, just indicate who you are so that we've got some idea of who we have on the line. So I can see we've got physiotherapists and commissioners, which is usually our two largest groups on an ARMA webinar, but we've got various others as well. And in a moment, when people have finished voting, I will pop up the results so that you can see that. I know we have some GPs registered. We don't yet have any GPs on the line. So I'll just give it another second or two. If anybody else wants to vote. Obviously not everybody does. So I'll just share the results of that. So our largest group is physiotherapists, followed by commissioners. And then we've got other therapists, managers, a few with policy roles, and one or two other. So that's just to give us an idea of who the audience we have here on the line. So welcome to everybody, but particular welcome to today's presenter, Dr. Louise Warburton, who is a GP with special interest in rheumatology and musculoskeletal medicine. And she is going to take us through how the service that she runs was set up and some of the challenges that they encountered along the way and some of the solutions that they found. So over to you, Louise.
Okay, I will start my talk. Can you see the slides, Sue?
Yes.
Yeah. So
visible.
Everything you wanted to know about setting up a musculoskeletal service but were afraid to ask. So when I was asked to do this webinar, I thought quite hard about what to cover, and there is lots of guidance out there about setting up services, commissioning services, but I thought I would give you a nuts and bolts view of what it was like, really, trying to set up a service. So, sorry, a little bit of technical. Can you see that okay?
Yes, that's fine.
Yeah. So I'm working in Telford and Wrekin, which is in the middle of the country, just north of Birmingham and on the way to Wales. It looks a beautiful rural county from this map, but we work in Telford, which is a small town to the east of Shrewsbury. So it's a semi-urban area, really. And I've worked here for about, well, on and off as a GP for probably 25 years, which is a long time. And as a musculoskeletal gypsy for about 10 years. There's a population of 173,000. It's quite a deprived area, so that a higher proportion of residents report ill health than the UK averages. We do have some quite affluent areas though, but there are high levels of obesity really and chronic diseases. So for a while I worked as a CCG board member, and I knew there were pressures in the system on orthopaedic weights, and as I'm sure happened in many other areas of the country, the CCG decided that it wanted to do something about this and decided to commission an integrated community musculoskeletal service in 2015. And this was off the back really of some work by a GP called Nick Tyndall. He was a local GP who was trained in sports medicine and felt that a physiotherapist could do a lot of the first assessment and intervention for patients going into orthopaedics. So lots of people were going in, many of them didn't need surgery really. So the CCG came up with a service spec. I was on the CCG at that time, so there was a bit of a conflict of interest, so I wasn't included much in these discussions. But the specification set up wanting a service that covered pain, orthopaedics, rheumatology and physiotherapy. And it wanted to be a community service with multidisciplinary working with local networks. But really looking back, this model was a bit oversimplistic. It's not until you get into something you realise how complicated it really is. But it was a good model to start off with. And the model initially wanted everyone to go through physio first. And the initial estimate was that about 80% of people would be referred in and see a physiotherapist, and only 20% would be more complicated and need to see an orthopaedic surgeon or a rheumatologist. So an 80-20 split. So before we had the new service, it was a fairly standard service. GPs could refer into anyone really. They could refer to an orthopaedic surgeon or to a rheumatologist. And we realised that many appointments didn't actually result in a surgical outcome or even a diagnosis of inflammatory arthritis. And this wasn't making the best use of consultant time, and it was expensive as well. And the CCG also realised that some patients with chronic pain and yellow flags and long-term conditions weren't really getting the best service from this type of offering. So this was the reason for a new service being tendered for. And this is the old model. So as a GP, sometimes you really had no idea where to refer. And we also had a small integrated community service, which I was working in. So that was myself and one extended scope physio. So the choice was to refer to us, maybe into the acute trust, or into the community rheumatology service, which was provided by the Orthopaedic Hospital in Oswestry. So it was a bit confusing, really. So the tender came out, and there were a lot of discussions with local providers. So I worked for Shropshire Community NHS Trust, I was providing this small musculoskeletal service. So the trust decided they would be a lead applicant for the tender in partnership with the local orthopaedic hospital in Oswestry, which is the Robert Jones and Agnes Hunt, and also our acute trust, Shrewsbury and Telford Acute Trust, that should be SAF. But the service spec was rather unclear in certain areas, and there was very little financial detail as to what the budgets would be. And obviously we asked a few questions about this, and the answers we got, because it goes through, I've forgotten the name of the body, but it doesn't go direct to the CCG, it goes to the official body who do the tendering. The replies we got back were sometimes fairly generic and difficult to understand. I mean, for example, we didn't even know whether community physiotherapy was going to be part of the tender. So quite large parts of the service spec were difficult to understand. And also the activity levels were quite opaque, really. It was difficult for the CCG to get an estimate of activity within all the different trusts. So the acute trust was dealing with acute orthopaedics. Their data wasn't very clean. They did provide data for the service spec, but generally it was quite hard to get a very accurate idea of how many patients we would be dealing with if we won the tender. And this has really caused issues going on. The estimate that was given was that we would likely get 11,000 referrals per annum. Also, another innovative part of this tender was that there would be a single payment per patient pathway. So it wasn't a tariff. So if a patient came in and saw a physiotherapist once, we would get the same payment as if they came in and saw a rheumatologist and were then on a care pathway for the rest of their life. So it was a new way of financing a service. And if the physio and MDT split of 80-20 was working, then it would financially break even, really. So that was the financial model we were working on. So we won the tender. We were up against several private providers, but we came in with a cheaper tender, and we were lucky enough to win. And this was to provide an integrated musculoskeletal service covering pain, musculoskeletal problems, orthopaedics, rheumatology, and physiotherapy, but not community physio. So not doing home visits, but providing physio within a clinic setting. And we called ourselves Telford Musculoskeletal Service. And we were originally a partnership of 5 local organisations running this new service. So that's the Acute Trust, the Shrewsbury and Telford Hospital, the Orthopaedic Hospital, Robert Jones and Agnes Hunt, a private pain provider called Pain Management Solutions, physio departments in the trust that I've mentioned, but also a private provider called the Maddox, and therapists from within the Shropshire Community Trust. So it was really a very multidisciplinary model. And we had a clinic hub and a spoke model. So we had a central admin hub and a central booking team. And we wanted there to be seamless pathways of care for patients with no referring back to the GP. So if a patient came in with one problem, say a hand pain, and they were found to have carpal tunnel syndrome, they would go directly on to see a hand therapist and then on to surgery if that was required, without ever going back to the GP. So from the GP point of view, this was a single point of referral, and hopefully the care pathway would be taken care of and they wouldn't need to be involved again. We were also asked to provide primary care education. So we did quite a lot of that as the tender started, visiting practices, telling them about the new service. We also had to come up with a new way of referring into the service. So before, it had been quite traditional with letters, dictated letters, but we came up with a pro forma, a referral pro forma, with a minimum data set. So we wanted there to be quality referrals, and anything which was just a single line, it might say hand pain, we rejected because there wasn't enough data. And we had a single point of referral for all clinicians, so that's GPs, first contact practitioners, as there will be now, advanced nurse practitioners. And this was all done on choose and book. So electronic referrals come in. They originally come into the Telford Referral and Quality Service, which was already established at the CCG, where referrals are checked for quality issues and then passed on to us. We screen for red flags and reject those. So we're a community service and we shouldn't really be seeing urgent cases such as 2-week referrals or possible cancer. So at the first stage of triage, we will reject those. And a lot of education went on, and it still does really, with GPs about what we do and do not want to see and what sort of referrals we like. So our MDT consists of podiatry, orthotics, nerve conduction, physiotherapy, rheumatology, pain services. We've got 5 extended scope practitioners and 3 GPs with a special interest. We went to the GPs with the form, the referral form, to make sure they were happy with it. We did have electronic issues initially with e-referrals. So at the Community Trust, we were using a patient administration service called Lorenzo, and this didn't really speak electronically to e-referrals. So there was a lot of admin task required around taking referrals off e-referrals and adding them manually into Lorenzo. So that initially we hadn't allowed for that admin time. So there was a lot more admin time taken up with the referrals. And we were getting about 80 a day, really, so it's quite a lot to deal with. And for 3 months, we were told that the service might be starting or it might not. And eventually we were given 4 weeks notice to get things up and running, which was not much time at all, really. And we were running around like headless chickens trying to get things sorted out. So we physically had to create clinics, book patients. And because we're a semi-rural area with the town of Telford in the middle, we've got some hubs, and that meant travelling across the county with notes and dictaphones. So this is a map of Telford.
So Louise, just to briefly break in here, we've had a question about the budget, which is do you have all of the budget for MSK orthotics, or just part of it for some shoe inserts?
For orthotics?
Yeah, where does orthotics fit in?
Yes, yeah. So we don't have the whole budget because there is a lot of inpatient orthotics and some in the orthopaedic department, surgery department. So we don't hold the whole budget for that, no. We just pay on a case-by-case basis for that. So this is our layout of our service area. I'm in the middle at Euston House, and this is where the main clinical hub is, but we are spread out quite widely. There was this community rheumatology clinic in a different place. We've got the local hospitals, and our admin hub was in a different place than the clinics, which caused problems, and it still is in a different location. So going forward, if you're trying to set up a service, I would strongly advise you to have your admin hub at the same place as your clinical work if possible, because you need to be walking backwards and forwards, talking to your team secretaries about patient notes. It just makes life a lot easier. So just a little bit more about the clinical triage process. So referrals come in on e-bookings, and they're read at the first stage by a team of Band 6 physiotherapists. So we have referral pathways, which were agreed with the GPs and are stored on the CCG website and on our website. So the triage is done against these pathways, really. Anything complicated or rheumatological is then sent through electronically to myself and the other GPs and extended scope physios, so that we can do a more in-depth triage. And we have access to blood test results and X-ray investigations. So a lot of the triage is around looking at the notes from the GP, so we get a referral pro forma, sometimes with an extract from the notes. We've tried to copy the last 3 consultations into the referral pro forma, plus a list of the patient's significant history, problems and medication, so that we have a fair bit of information. But the triage process is really important to make sure that the right person sees that patient. Originally, we weren't sure how many referrals we would get a day. I said 80 a minute ago, but it's actually more than that. It's about 300. So initially when we started, we didn't realise how much time that would take. And the physios who do the first stage triage were allocated an hour a day, but it was actually taking a lot longer than that. So there was a lot of clinic timetable manipulation that we had to do to make sure that there was enough time for this process. We also do advice and guidance, so we get paid for that, and that's orthopaedics, rheumatology, pain, etc. So the challenges when we first set up was trying to work across different organisations, the acute trust, the orthopaedic hospital, the pain service. We all had different computer systems. They didn't talk to each other. We needed data sharing agreements for clinicians going into different clinics which were run by different trusts. So this was a real headache at the beginning, and there wasn't really much time to do all this. And at the acute trust, anything which required a surgical operation was referred out of our service into the acute trust. But we didn't really do the change management of the pathway very well with the acute trust orthopaedic department. And going back, I would certainly allocate much more time and effort to explaining carefully to everyone what's going to change, how it's going to change, what the processes are. So that's a big learning event for us.
Louise, we've had another question come in, which is about time.
Yeah.
How much time is typically spent at initial and second stage triage?
Okay, so we've refined it now, but I would say it's at least 2 hours a day for a physiotherapist at the first stage. And for the second stage, myself, it's about half an hour to an hour. It's got much slicker, the system, since we've got more used to it. But you need to allow about 2 hours a day for that number of referrals for your first stage triages to answer that. Initially, when we set up as well, we had weekly operations meetings with the acute trust to try and address the difficulties, but all that was very hard to manage, and it never ran very smoothly. So our clinical admin hub was very cramped as well. We didn't have enough room for all the team, and everyone was working under difficult conditions at the beginning. So the first 5 months that we were working, instead of having 11,000 referrals per annum, the equivalent referrals would have been 15,056 per annum. So there was a lot more activity coming into the service than we thought there would be. This has settled down now to around about 11,000, but the initial interest in a new service creates a lot more referrals. So that's a warning for anyone setting up a service. Anything new is going to be popular. But we did manage to adhere quite well to our 80-20 split initially, so that the majority of people were seen by a physiotherapist. Fewer people were seen by orthopaedics or rheumatology. I see there's a couple more questions coming in.
Yeah. So these are particularly around triage. So where did the triage staff come from, and what jobs did they stop doing to undertake triage?
So they're band 6 physiotherapists, and they work at the local acute trust but do work for our service. So they are obviously taken out of their normal clinical activities to do this triage. And they require some training, obviously, and mentorship and support to ensure that the process is accurate and safe. So they need, you need backfill probably for 2 hours a day for someone to do their clinical work.
And what parts of the triage are first stage and second stage? I'll say a little bit more about that.
Yes, so probably 95% of it occurs in first stage now. And the only things which come through to second stage are clinical queries, or should this patient even be in the service? They might have had cancer 2 or 3 years ago. Is this a recurrence of the cancer? In which case we shouldn't be seeing them. And anything rheumatological. So is this acute rheumatoid, which needs to be on a fast track early arthritis pathway? So I would assess those referrals, get as much information as I could from the letter and the blood test results. And anything which is just a difficult letter to interpret, that type of thing. So you need somebody as a clinical lead to be able to answer those types of queries. So in the first few months of the service, we did reduce onward referrals to acute orthopaedics, which is what the service was set up.
So just before you go on, more questions about triage.
Yeah.
So can you explain a bit more about what the band 6 physios are doing? Is it a paper electronic triage and then forwarding on to second stage?
Yeah.
Is that how it works?
So it's all on electronic triage, which is in the Choose and Book or e-booking software. So attached to any referral that comes through electronically is a referral letter and a sort of an audit trail of who's read the referral, which practice it came from. So you can open up a referral letter on Choose and Book, e-bookings, read it, make a decision. So there are some options then about I'm not sure how this was set up. Obviously, it was done through our admin team. The options are refer this patient on to second stage for me to read or one of the other team, appoint this patient with the correct clinician, and then there's a free text box to write suitable for orthotics or for nerve conduction, and an urgent or a routine box so that you can tick whether it's an urgent or routine referral. So it's all done electronically. There should be no paper flying around. It's another question about that.
Yeah. So does the electronic system you use allow you to see GP records when making triage decisions?
Does it what with the GP record?
Can you see the GP records?
No. So we're not electronically connected to the GP records. So our community trust had a new patient admin service last year, and instead of choosing EMIS, they chose Rio. So in some areas they use EMIS for similar services, and then I think with the correct security settings, obviously you would be able to see patient records, but we can't in our service at the moment, not GP records.
And then there's a question about self-management advice. So are you able to offer self-management advice to the patient at stage 1?
Not really, no. The patient wouldn't get a communication from us apart from a letter to say your referral has been triaged and you will receive an appointment for physio or whatever. But if we chose at that point, we could send advice, but we haven't done that with the appointment letter. In the pain service, they do send out information and questionnaires at that stage for patients to fill in.
So that first appointment would then be the place for discussing the self-management?
Yes.
Yeah. And then what percentage of the e-booking referrals to the service are from GPs?
Well, they're all from GP practices, so we wouldn't take a referral from secondary care, for example. And I would say 95% at the moment are from GPs, and 5% would be from practice nurses or physiotherapists. Okay. So further day-to-day issues that we had when the service first started was about access to MRI images. So we already had a community MRI service provided by Alliance Medical, which came in a lorry and parked up outside what's now our main clinical hub. So GPs were, prior to our service, allowed to request MRIs directly with this service. But the problem was the images from these scans were not visible in the acute trust. So if we referred a patient out of our service into the acute trust for orthopaedic surgery, often these MRI images were not visible to the consultants. And this caused quite a lot of difficulty in the early stages. And it's quite a complicated process to unpick, but obviously there's an electronic image. It's got to be transferred from one service to another, then it's got to be uploaded onto the acute trust PACS system, and all that just wasn't working. And it was initially used as an acute risk, really. The acute trust felt that they couldn't work with us because of this risk, and this resulted in us having an external peer review from Circle in the early months of the service. I'm pleased to say it's obviously been sorted out now and images are transferred much more easily. So another question, Sue. So
there's another question which is about self-referral to physiotherapy. Is there any self-referral to physio as part of the pathway?
No, there isn't at the moment. It's something that we've talked about, but we've not implemented that as yet. So I'm pleased to say that the peer review visit from Circle went quite well, really. There were risks around the images, the MRI images, but that's been sorted out. After about 12 months, we realised that the partnership, so we were in partnership with these other organisations, the Acute Trust particularly, the partnership with them wasn't working. And it was really around financial risk, that the acute trust didn't want to accept the financial risk that there might be in running a new service. And eventually they decided they couldn't sign a partnership agreement, and we developed a more looser working arrangement. And the Community Trust, who I work for, took on the prime provider role in this service. So we hold the financial budget, and we subcontract activity to the pain service, to the acute trust, to the MRI imagers. So we hold the financial risk, really. It's quite difficult to manage the clinical governance for such a large organisation. I'm clinical governance lead, so setting up the initial meetings was quite difficult. Who was responsible for complaints and significant events? And obviously in the first few months of the service, these meetings were quite operational. Lots of time was spent discussing what went wrong with a referral, why was there a delay in that patient's pathway. And it took quite a long time to sort that out. So I've got a lot more experience now on how to run a clinical governance meeting and how to set those up. So it works much better now. So we've innovated as the service has gone along. We've tried to improve the patient journey within Telford and Wrekin. We've worked in partnership with Keele University. So I've been a senior lecturer there. I'm still an honorary senior lecturer, doing a lot of work around osteoarthritis. So we were able to train all the local GPs along a management pathway for osteoarthritis, so that there was some patient self-management there, and we were hopeful that it would reduce referrals into the service. I've also worked with ARMA, with the Clinical Networks project, and quite early on in the service we invited healthy lifestyle advisors from the local authority to come and use a room in the service once a week, because there were loads and loads of people being referred in who were inactive, needed advice about exercise and weight loss. So that's worked very well. We also have trained some community champions. So these are lay people who I've personally trained up about joint pain, managing osteoarthritis, promoting exercise. And we've also been in partnership with Public Health England here on training these community champions. So some more questions.
A couple more questions. So we've got lots more questions. We'll start with, do you have SSTP included as part of National Spine Pathfinder projects?
SST, what's that, sorry?
Pat, can you type it a bit more about what SSTP means?
I know what STP is, but we don't have a special tariff for managing spinal pain, if that's what you mean.
Okay. And are you part of a national FCP pilot, first contact practitioner pilot?
We are running an FCP pilot, but it's not part of the CSP pilots. We're doing that more as our own project.
Okay. Pat says spinal triage practitioners.
Right. No, we're not part of that pathway. No.
Okay. So who books patients into C and B slots, and is there scope patients could book themselves into these slots online?
Into which slots, sorry?
So C and B.
Oh, choose and book?
Choose and book.
No, it's not directly bookable. I think that's what you mean. So some services offer slots that patients can choose. So we haven't done that yet, no. We're still at the point of sending out a letter to a patient saying, we've asked them actually to ring in and arrange an appointment to try and reduce the number of people not arriving for appointments. So that's worked better.
Okay. And then a question here, with such a high proportion of patients being managed by a physiotherapist, first with initial triage and then onward referral, have you considered a more streamlined pathway, putting advanced practice physios at the front of the pathway to manage signpost referral as appropriate? Well,
the physio team at the Acute Trust has got advanced practice ESPs, bands 5, 6 and 7s, working in one department. So there is a lot of discussion and team working that goes on before a patient is ever referred on to see anyone in the MDT. So I think a lot of management goes on that below the surface that I'm not aware of, because there is such a well-established team there. Any more?
That's all the ones that have come in so far.
So I've already talked about this. Apart from the bottom line, the community champions and all the neighbourhood working that we're involved with, obviously fits in really well with the STP in the local area. So our surgical pathways, the orthopaedic pathways, were challenged due to winter pressures and there being no beds in the local acute hospital. So we were fortunate that the local Nuffield Hospital in Shrewsbury had got lots of capacity. So they now do quite a lot of our orthopaedic surgery. And the waiting times have come right down. So that's been a success, really. We've had talks with the Orthopaedic Hospital so that they will also become one of our surgical providers. And we've been able to do nerve conduction tests locally in the clinic rather than referring patients to Wolverhampton. So I can see there's a few more questions.
Yeah, so some of those relate to providers. So how is it decided if a patient is seen by Maddox or an NHS Physio? Do you have selective criteria, or is it?
It depends on where they live, really. Yeah, it's more on where the patient's offered choice. So a member of the admin team would ring them and tell them where the physiotherapy was available. So we've got some in Newport, which was the far northeast of the patch. The Maddox is in the southeast. So it's more around geographical location, really. But it's important to note that the practitioners who work in the private sector at the Maddox are involved in our clinical governance meetings and have links in and mentorship so that they are part of the wider team.
Okay, and then do your commissioners know how much money has been saved? Do you know the quick targets?
It's been quite hard to find out how much money has been saved. I know that the MSK spend overall within Telford and Wrekin has fallen. But as to exact figures, they haven't been shared with us, no, not yet.
Okay, and then there's one here. The evidence emerging from the first contact practitioner pilots highlights that most patients can be managed in general practice, activated to engage in self-management. Are your physios not talking with you about first contact practitioner? So I was going to ask about this in terms of future development of your service, because obviously it is now being rolled out.
Yes. So
that might change the landscape that you're working.
So 3 local GP practices wanted to start a FCP program, and we have used our physiotherapists. They're going into these general practices so that it's part of our wider team, really. So we're just starting that. It's been going about a month, and it's not part of the CSP pilot, as I said. But yes, obviously we are looking at expanding that role, doing more of the management actually in primary care.
Yeah, which fits with the way I think that the FCP rollout is being envisaged, which is about redeploying existing staff rather than having an extra tranche of recruitment.
Yeah, I think it's really important that those physiotherapists are part of a wider team, because it must be very isolating to go out into a general practice and try and manage patients there when you've never done it before. So I'm keen that we still continue to work as a team there. Yeah.
And then do your physios in a triage role use the start back tool?
Oh yeah, yes we do. On our referral form there is a box for the start back score. So if a patient has spinal pain, we ask the GPs to fill that in. It's not always filled in. If it hasn't been done, then it would be done at the first appointment, first with either a physio or an ESP. So we definitely use that, yes. Okay. Another question. Do you want to take that one?
Well, it's more a comment. Absolutely agree. Really important that the FCPs are part of the GP team and also the integrated MSK pathway.
Yeah. So we have developed our own internal pain pathway as well. So we have the external service, Pain Management Solutions, who are now managed by InHealth. But we realised that there were a lot of patients with widespread pain, chronic pain, and we weren't managing these very well. So we've developed our own pathway with a more exercise-based approach. And our Band 7 physios have developed an internal triage pathway for this. They've had 93% improved scores on the MSK-HQ PROM. So generally that pathway is working very well. We're also training up ESPs to give joint injections. We obviously had ESPs who were trained to do this, and we have ultrasound guided injections, but we're training up more people to be able to do this. And I also have brought a mental health support worker into the team, because a lot of people with chronic widespread pain have issues with anxiety and depression. So we now have a mental health worker who will be here once a week to see our patients, and this is part of the wider IAPT services which are available to primary care within Telford, and this has been very helpful as well. Are there any more questions? Yeah.
Oh, do you offer a choice of face-to-face or telephone consultations for routine low-risk physiotherapy referrals?
No, we don't have any telephone appointments at the moment. So we've never used that. We've always had a face-to-face assessment.
Okay. And how do you see the model, this is sort of expanding on what we were saying before, how do you see the model integrating with the in-house first contact practitioner triage model? So in GP practices?
Yes, yeah. I see us having a wider network of physios working in GP practices and fewer physios working in the clinic setting, but still, as we've said, part of our service, so that they have mentorship and there's governance over what's happening.
Yeah, so you're more seeing your service providing support to the FCP,
yes,
than the FCP providing support to your service.
Yes, yeah.
Yeah. And then do you offer a functional restoration program as part of pain management?
Not really. There is one at the Orthopaedic Hospital in Oswestry, but that's not within our service. So we could refer to them if we felt it would benefit. The InHealth Pain Service run a pain management program, which isn't an inpatient one, but that's a proper pain management service with numerous appointments and a CBT therapist input. Another question.
And do you use StartBack to identify matched treatments, and do you offer combined physical and psychological approach to treatment options?
In a way, yes. Anybody who's gets a high score on the StartBack questionnaire will end up probably seeing a more experienced physio, and then maybe going into the pain program that I've just described, which is run by Band 7 physios. Or they may end up coming in to see myself or one of the ESPs. So in a way we do, yes. So challenges to at the moment are reducing imaging waiting times. So we're working with our local MRI provider to open up faster access. And we'd really like to run a one-stop MDT clinic. This has also been an ambition. So a patient might come in and see myself, and I think they need to see an orthopaedic surgeon, but the surgeon will be there on the same day or the next day and see someone virtually immediately, rather than there still being a wait to see different practitioners. And we're also trying to set up an early arthritis service with ultrasound training. I'm hoping to do that myself, so that we can have an early arthritis clinic. And obviously the triage process has refined hugely over the last 3 years. And that's been the best part of the service, I think. It's much slicker now. People go to the clinician that they need to see. We give feedback to the referrers. And through that, we've developed our new musculoskeletal pathways for pain and fibromyalgia and osteoarthritis. So the right person is seeing the right patient at the right clinician at the right time. And over the last 12 months, we've had a bit of a challenge on waits to see rheumatologists. The rheumatologists were seeing a lot of people who didn't have inflammatory arthritis. So we've done a sort of super triage. So there's electronic triage by myself, and I'm seeing anyone who, not people who have obviously got acute inflammation on a referral letter, they would still go to rheumatology. But I've seen more of the people who would fall in the grey area between inflammation and not. And I see those very quickly on an acute pathway within 2 weeks. So we've managed to reduce altogether the number of people seeing a rheumatologist from 435 over 9 months in 2017 to 266. And I thought there may be a jump in the number of patients that I saw and was referring back to rheumatology, but there hasn't been really. So I'm managing to see patients who don't have inflammatory arthritis but do have joint pain for whatever reason, giving them an explanation and a management plan, and that's freed up some of our rheumatology capacity, which has been very good. So what about the future? So it's a 5-year tender, and we've got 2 years left. There is financial challenge. We have got a recovery plan in place because it's proved more expensive to run the service than we anticipated. Because we only get the one payment per pathway, some patients are complicated and need to see several clinicians, and that this payment system doesn't really work very well for people like that. We introduced the new patient administration system last year, the year before actually, and we now use Rio, but that caused a bit of havoc, so we couldn't book any appointments for 4 weeks. But despite all these problems, we've got excellent patient satisfaction ratings. We get about 98% on the friends and family. CCG are currently reviewing the tender to see what will happen going forwards. Hopefully it will be renewed or renewed in some other form, but we continue to innovate and change pathways. And that's the end.
Brilliant. Thank you very much, Louise. If anybody, we have a little bit of time left, if anybody has any other questions that you'd like to ask. I think this was a really useful webinar in terms of being willing to talk about some of the challenges and some of the ways you've adapted and learned throughout the process. We are approaching a couple of other people who have MSK services of different models so that we can do webinars on different ones, and I'm really hoping that they will be willing to do the same. I think it's very useful for people to hear, not just what the final lovely shiny thing looks like. Actually got there is quite important. So there's no new questions seem to be coming up, so I think that's probably because we've covered. Oh no, here we go. Oh, that's just a thank you. Really useful to highlight the challenging commissioning issues and also the short time scales. Yeah, as I was saying, really very useful and open webinar. So thank you very much, Louise, for agreeing to present the webinar.
Thank you.
Thank you to everyone who has joined us. As I say, we do have future webinars coming up. I'm hoping to find some other different models so that we can highlight those. In March, we've got 2 coming up, one on implementing the National Back Pain Pathway, which is already proving very popular. And then we're just about to start promoting one on integrating musculoskeletal and mental health services, which I think is going to be a really fascinating one. So do look out for those. Everyone who signed up for today's webinar will receive an email once we've got the recording up, so that you can watch the recording back if you want to, share it with other people, but we'll also include things about how to sign up for future webinars. So thank you all very much for joining us, and thanks again to Louise.
Thank you.